Hello, we are back. And our next talk, I am going to talk about CPAP compliance. So we'll go. No conflicts of interest to disclose. This is our accreditation statement. We are providing CME and CEU through the American Academy of Sleep Medicine. These are the objectives I hope to accomplish in this presentation today. So let's go ahead and get started. This is an old statistic, as you can see, but it reports a wide range of CPAP compliance, as low as 29% to 83% stick with CPAP over the long term. A lot of that is because there are not a lot of good studies, and it's a difficult thing to track how many people are using it successfully. It's getting better with downloadable machines, but over time it is hard to know who is actually using the CPAP consistently over the long term. I think nationally it is about 60% of patients who are prescribed CPAP therapy stick with it long term. CPAP used to be the only alternative. I've been doing sleep medicine for over 30 years, and that was the only thing we had to treat sleep apnea when I started. Now we have a lot of good alternatives. If somebody is intolerant to CPAP, they can go and look for a dental device, a mandibular advancement device. We have the Inspire device. There are surgical options. So there is a lot more for patients out there to use as alternatives, and we need those alternatives. Not everybody is going to be able to tolerate the CPAP, but hopefully we can find out what we can do as sleep techs, DME techs, physicians, providers, to make our patients more successful. If a patient has a bad experience using CPAP the first time, research shows that it's much more difficult to use it successfully in the long run. I find this to be true a couple of reasons. A sleep lab, if they have a bad experience using the CPAP for the first time in the sleep lab, that can set the pace for whether or not the patient is going to wear it long term. So it's important that we do all we can and do our part as sleep techs to make that first night the best experience it possibly can be for the patient. CPAP compliance can vary by region. It is hard to track. I think in regions where you have your better DME follow-up, good strong programs to support the patients, the compliance will be higher. Many do well initially because they're feeling some benefit from the CPAP, but they stop. So the initial statistics may not be accurate because patients may give up on it after that initial period. If a patient is using the CPAP device less than 4 hours a night, it's generally a hallmark sign of future noncompliance. So I know sometimes our patients want to start out slow. They want to only wear it a couple of nights and work their way up to it. But if we see that during that initial compliance period that the patient's wearing it less than 4 hours a night, it's going to be much more difficult for them to be successful with it in the long term. As high as 50% of our patients give up on CPAP shortly after the titration if they're not followed closely during that first week after the setup. Home care companies need to make sure that they make initial contact shortly after starting the therapy so that we can address any issues that there are to the therapy and make the patients as comfortable as possible and get them off on a good foot to using the CPAP. These are what I consider to be the three biggest issues why patients are non-compliant. Number one is mask issues. Ill-fitting masks, masks that are uncomfortable, masks that leak a lot are the biggest reasons people want to give up on using. They think it's uncomfortable and cumbersome. So mask fit is largely a part of why patients are non-compliant. Ineffective coaching of the patient to get them through that adaptation process is another big reason. And sometimes the wrong delivery of PAP. Some patients don't take to auto PAP. They do better on a straight pressure, or they may have complex sleep disordered breathing issues and need a different delivery system. BiPAP versus CPAP, for example. As sleep techs and as DME techs, earning the trust of the patient when you're using CPAP initially is important, and getting them to accept the therapy for the long term. If you have time during the sleep study, sometimes it's useful to try the CPAP on ahead of time. Patients have an opinion that it's worse than what it actually is. So it helps if you have them try it on ahead of time. Show them how to remove the mask. Some sleep techs do not want the patient removing the mask because when they take the mask off, the electrodes will come with it. But I think it's helpful to show the patient, here's what the straps are, here's where it's connected, this is how you disconnect the air, this is what you got to do if you got to hurry up and get it off before I get back in here. Just giving the patients that control sometimes is helpful to reduce their anxiety. Letting them hold it up to their face and just experience that feeling and sensation of the airflow and breathing against positive pressure before the mask is actually strapped on. I let the patient hold it up to their face themselves just to kind of get used to that air feeling. Explain to them that this is the best alternative available to fix the issue of sleep apnea. We do have other alternatives. Nowadays, we have mandibular advancement devices, we have surgical options, we have the Inspire device, and we need those alternatives for people who can't wear the CPAP. But explain to the patient that for now, right here where we are in the sleep center, this is the best alternative available to fix the problem. Also explain the benefit of the therapy. You're not going to be tired anymore. You're not going to snore, so it's going to improve the relationship with your bed partner. It's going to be healthier for you because it reduces your risk of heart attack, stroke, and high blood pressure. And I also explain that we're not going to make them wear it if they're not able to. Again, just making the patient feel as if they're in control the whole time. When using CPAP for the first time, I like to start with an evaluation and assessment of the patient breathing. Just watch them breathing as they're sitting in the chair. Are they doing a lot of mouth breathing? Do you hear obstruction as they're drawing in the air? Ask about chronic dryness, allergies, sinus infections, deviated septum, or anything that could cause a decrease or restriction in nasal breathing. I like to assess their nasal airways by having the patient occlude one nostril and breathe through the other. I always say, can you go like this for me? And have them hold one nostril shut and breathe through the other. Then you can kind of hear how adequate and patent their nasal airways are and give you an idea of how well they can breathe through their nose. Ask the patient about issues with claustrophobia. Many times our patients with severe sleep apnea are claustrophobic just because they've been struggling to breathe during sleep for many years, so they're nervous or anxious about having a mask applied during the night. And it's best to assess that ahead of time if you have the time to do that and then discuss it with your patient. And then always start with the mask that best meets the needs of the patient breathing. When you're trying CPAP for the first time, explain that feeling of resistance, because it is a weird feeling that you're going to be breathing against resistance, and that's what holds your airway open. Sometimes it's easier to have the patient in a reclining position when you apply the mask and the pressure. Have them relax and just focus on their breathing. There's always a debate about whether we should have flow going to the mask when you apply it or not. I think flow going to the mask. I like air. I'm a respiratory therapist. I love the concept of of good breathing and air, but I do think that flow can be confusing for patients sometimes as the mask machine adjusts. Especially when you turn it on, you know how it ramps up to seal up any leaks, and when you're coming at them with a mask and that high flow is blowing until the mask is sealed, it might scare them. So sometimes get the mask on comfortably and then apply the air is what I think is best. Use comfort features like C-Flex, ramping, EPR, if that makes the patient feel more comfortable. I think the comfort features work best on patients who are a little anxious and who are naive to therapy. If you put it on a patient who's used CPAP for years, generally they're going to hate it. You may have to start with a higher pressure or a lower minimal pressure for comfort also, based on the patient's breathing needs. You know, if they say it's not enough air, it's too much air. I find also a full face mask can be helpful for patients who say it's too much air or not enough air. And you think, well, why would it be too much air? You know, if their nasal airways are diminished and they're not getting good airflow, it can feel like they're not getting enough air, or it can just feel, I think, like the air is blowing all around, and they'll say sometimes it's too much air, but when you put a full face mask on, they're much more comfortable. So keep that in mind. If your patient says it's too much air or it's not enough air, you may want to consider switching to a full face mask. As far as the comfort settings go, the anxious patients, like I said, seem to benefit the most. They may be useful when initiating therapy in the lab or starting it for the first time at home. It was not available in the first generations of auto CPAP, but it is available in all the high-end PAP machines. C-Flex and EPR may not work. And again, these are just comfort features that can be added to the therapy. They may not work for patients with chronic obstructive pulmonary disease or experienced CPAP users. I like all-night titrations. All-night titrations give the tech more time to try things and to adequately titrate. Sometimes prescriber or physicians, providers will prescribe Ambien if the patient is struggling a little bit getting used to the therapy, so that they can, you know, have a few good nights and get through the process a little less aware that the mask is on. In the sleep lab, you want to make sure that you fix leaks when it is leaking, because leaks can definitely wake a patient up also. And if it's for small mouth leaks, you may want to add a chin strap if that's needed, or switch to a full face mask, of course, if that's indicated. Like I said, I like to give the patient what they're most comfortable with. You know, let them try the mask and whichever one they're going to wear, because it's not going to work if they're not going to wear it. So make sure that they have what they feel the most comfortable with. You can switch to a full face mask if you have adequate humidity and the pressure is adequate and the patient continues to open their mouth. If you do not have adequate humidity, the patient will tend to open their mouth also. So make sure your humidity settings are adequate. and you have enough pressure to overcome the obstructive events. When the patient is using CPAP initially at home, sometimes things like nasal spray to open up the nasal airways over the short term can be effective, as are the breathe right strips that you can buy over the counter just to improve nasal breathing. And communicate to the patient that they have to let you know in the sleep lab the first night, or if they're trying the therapy at home, what are the discomfort issues, so that something else can be tried or something can be done to alleviate that. Sleep labs and home care companies really got to work hand in hand to get this patient started on therapy as soon as possible. Sometimes insurance is a hang up for us because we're not able to get the patient started as soon as we would like, because we have to wait for authorization from the insurance. That's becoming more and more of a reality to us in our day-to-day life, but it is important to stay on it with the patient so that they follow through and get the therapy as soon as possible after the titration. So otherwise, it seems like the more the time goes by, the patients think it's not important, or they get time to think about it, and oh, I really don't know if I want to do that. Kind of ride the wave of when they feel a little better because they slept good for the first night in years in the sleep lab. Try to get them started as soon as possible so that you can keep that going. They do need to follow up with their sleep physician a few weeks after starting the therapy. Of course, Medicare, it is mandatory to have a follow-up visit 31 to 90 days after the initial start of therapy, and that's a good idea at any rate, even if it isn't a Medicare guideline, because it gives the patient a chance to let the provider know how things are going and if there is anything that needs to be changed or evaluated at that time. It is, in the home care world, it is important to include the significant other in the phase of the treatment, education, setup, follow-up appointments, so that the patient has that support person at home also to help them stick with it. And I always tell patients, don't give up on it and don't put up with it. Let us know what it is that's an issue, and we'll try to resolve it to make it as comfortable for you as possible. If your sleep lab is ambitious and has volunteers that are willing to go the extra mile, facilitating an awake support group for patients can be extremely helpful. Just putting patients in touch with patients, because they have ideas of what works for them, and educating each other on getting through the first initial process and making CPAP successful in the long run. It's also important to reinforce the patient perceptions about sleep and their daytime functioning. Try and make them realize the benefit of, well, maybe this is making me feel a little better, sleep a little sounder, I do have more energy in the later afternoon, that sort of thing. As far as mask fitting goes, it can be very helpful to use sizing guides. I do recommend it. All of the masks, the high-end masks nowadays, come with a sizing guide, and it's a good starting place. So learn how to use your sizing guides in the sleep lab, and so that, don't trust your judgment, your memory, think you can tell by looking. Go ahead and use the measuring tools provided to us and try and get the best fit possible for the patient. Learn and use all the available features on the mask. Some of them have, if you adjust the strap here, it tightens this part of it up. Interchangeable cushions to make the sizing more accurate. So learn all those different features of the mask. One thing I like for sleep labs is fit packs that come with several sizes of cushions in one pack. So you can open up the pack, it's leaking a little bit, you got another cushion you can pop on, try a different size. Very efficient and helpful in sleep labs. Also, make sure the sleep team has regular contact with the vendors. Vendors are more than happy to come in and do mask fitting workshops and training on their mask, show you the different features on the mask and where the strap should sit and how it should be adjusted to make it the most comfortable for the patient. You should have the mask snug enough to avoid leaking, but not so snug it's uncomfortable. And notice I'm using the word snug. When I talk to the patient about tightening the mask, I like to use the word snug instead of tight, because tight somehow indicates that it's going to be or gives the impression that it's going to be uncomfortable. So have the mask snug enough to avoid leaking, but not so snug that it's uncomfortable for them in any way. Once the mask is secured, sometimes if you just pick it up and reseat it on your face, it seals up any of those little oddball leaks that the patient may have. So get it in place, then pick it up and reseat it. Have the patient return demonstration, show you they're comfortable putting it on, taking it off, and encourage the patient to handle the mask as needed. In the sleep lab where I am the facilitator, we have patients come in for CPAP consults when they're struggling with their therapy. And what I find oftentimes is the patients are not adjusting the mask on their own. They have to learn that, when you turn over at night, when the straps loosen up a little bit, they may have to undo one side and make it a little tighter, or they're just not putting it on tight enough from the get-go. So encourage the patient to get used to handling the straps and handling the mask and adjusting the straps as needed. It's best if the patient can get a higher end CPAP machine that can be changed to many of the different modes, so that if one mode isn't working right for the patient, they can get things can be changed and manipulated either remotely or by having the patient bring in their machine without getting a new machine. And many of the high-end machines have these features and capability on it. Downloads are extremely helpful. Any of you remember when we didn't have downloads? What did we do? How did we track what was happening at home? But now we have internet-based programs where we can look in, see is the patient wearing it, how are they wearing it, are they leaking it, what is their AHI? Very helpful to providers, text, and DMEs. And required by Medicare, of course, to track compliance. So I think it's important that a therapist is knowledgeable in the basics of downloads in regard to mask leak and what is appropriate for each mask. As you know, the different masks have different leak values, and you need to know what leak value is acceptable for each type of mask that is utilized. Explain to the patient the disease process and the effects of sleep apneas on the other systems like diabetes, risk of heart attack, and increased risk of heart attack and stroke. Explain the long-term effects of untreated sleep apnea, drowsiness, safety issues with driving, how it can affect your mood and your concentration and relationships. Snoring can cause people to not be able to sleep in the same bedroom and can cause hostility when one partner can't sleep because the other one is snoring. So relationships can suffer. Relationships can also suffer if somebody's not getting good sleep, and their mood is irritable. So explain what sleep apnea, the kind of effects it can have on us and our body systems, and explain the therapy to the patient and how it works. That it uses air pressure to splint the airway open, and use the appropriate therapy based on the sleep diagnoses. I'm just going to briefly run through these. This is doesn't have a lot to do with compliance, but like I said earlier, if you're not using the right type of PAP to treat the specific disorder, it can be an issue and it can lead to non-compliance. If a patient's having a lot of central apneas on the download, they should go back to their sleep provider and discuss whether or not they should be retested, or if a question of adaptive servoventilation, which is the type of PAP that is used to treat central sleep apnea, Shane-Stokes breathing. AVAPs or IVAPs, if a hypoventilation is an issue in very large patients or patients who have restrictive breathing disorders, they may need some assistance to their breathing, so that's when AVAPs or IVAPs is useful. Bilevel has been around a long time, like BiPAP-S, no rate assistance, but it is two pressures, one pressure when on the inhalation and one on the exhalation that is lower. It can be useful in assisting breathing in patients who have some hypoventilation. Can also help patients who are having tolerance issues. Some patients may find BiPAP more comfortable or more tolerable. And in Medicare patients, sometimes if you are to the end of that 90-day compliance period where you have to have 30 days of compliance in order for Medicare to cover the device, if the patient is non-compliant with the CPAP, BiPAP can be helpful. And then there's auto BiPAP, which automatically adjusts the IPAP and the EPAP to overcome this obstructive apneas. Downloads are an important measurement of compliance. We have some AHI types of events, leak information that is available through downloads. There are web-based programs that allow physicians, providers, sleep labs to access compliance data 24/7. And it's very important for home care professionals, sleep physicians, and DME to be experienced at reading these types of downloads. If a patient comes in for a CPAP consult who is struggling on the therapy, that's the first thing I will do is pull up the download. Are they even wearing it? How much are they wearing it? Where is the leak at? Do they have an elevated AHI? Are there a lot of central apneas occurring? Well, that can all be useful information to help get the patient more compliant. Let's talk a little bit about AutoPAP. AutoPAP is becoming big these days in the world of home sleep apnea testing because without in-lab titration, the patient is started on AutoPAP. So sometimes there is no titration data to review. If the patient comes in for a titration, sometimes the providers will still automatically order AutoPAP. And it sounds good in theory because, why use a pressure of 12 if they only need a pressure of 7 on their side but 12 on their back. But it is important that the titration data be carefully reviewed if the doctor is going to order auto PAP. Some patients are definitely more comfortable on straight pressure than that auto adjusting. Everybody's different, and it is something that the patients do have to communicate with the physician how they're feeling on the therapy, and the physician has to closely monitor and use the best type of device for to overcome the apneas. What I find with auto is people with very severe sleep apnea, they don't always do well on auto because they need a higher pressure and it doesn't tend to ramp up fast enough to overcome those apneas. And then the patient feels like they're suffocating and they rip off the mask. Also, high leaks we have to be aware of can cause upper airway drying, therefore making compliance more difficult. If the patient is ordered on auto CPAP, you should make sure that the minimum pressure is adequate for comfort. Not a good idea always, just sometimes a physician will just set a wide open pressure, and that's okay if you have no idea, if you have no titration data to go on, just to see what the download will show and then tweak it later on. But typically a minimum pressure is set at 5 to 7 and a max of 20. Ultimately, the lowest titration pressure -2 and the highest titration pressure +4. And you need to be aware of limitations like apnea cap, where, for these patients who have severe sleep apnea and maybe have repeated apneas, the machine has features built into it so that it doesn't turn up too aggressively when the patient's having central apneas, and sometimes will not be adequate for patients with severe sleep apnea. They would do better on a straight pressure. So again, auto CPAP automatically ramps up to eliminate snoring and flow limitations. Some patients prefer it to straight CPAP. Something else to be aware of is that it does not always work good for patients with chronic pain, with frequent PLMs or leg movements or other movement issues, because when they're moving due to pain or leg movements or other issues, the auto CPAP will ramp up thinking they're having apneas and need more pressure. So it does not always work well for those patients. Again, it may not aggressively enough adjust for the high needs of patients who need high CPAP pressures. Humidity is extremely important and medically necessary to prevent dryness of the upper airway. If the humidity, however, is too high, what we tend to get is condensation in the CPAP hose, and that wakes the patient up with the sloshing of water in the CPAP hose. So those hose covers can be useful. It covers the hose and and heated hoses have really helped this problem immensely. But those hose covers can also, like a fleece material over the hose and keeping the hose under the bed covers also can help decrease condensation. Also, just the room, being aware of the room temp and not having the room temp overly cold. Patients on a lot or certain medications can have increased dryness and have increased humidity needs, so be aware of that. Sometimes reviewing the medications the patient's on, and if they're complaining, especially of dry throat or things like that, to increase and adjust that humidity. Regional climate may differ from one area to another too. So if you live in a more humid region, you may have less need for a humidifier than if you live in a drier or more northern climate. These are all symptoms of inadequate humidity, and some things we may hear our patients complain about when the humidity, they need adjustments to the humidity with their PAP. They might say they have a dry nose. They might say they have a runny nose because the high flow of air is drying out the upper airway. A runny nose because when the upper airway is dry, the nasal mucosa will create secretions to try and lubricate it. Mouth leaking when there's not enough humidity, it's a natural response to open the mouth and try and get more airflow in. Sometimes they'll complain of ear popping or air swallowing, which is a mechanism to create saliva and moisten the airway. So I would recommend that you start with the humidity setting at midway, maybe even higher for auto. Heated hoses are essential and will increase the humidity. Encourage the patient to replace their mask, their cushions, their accessories, and other equipment as frequently as the insurance provider will allow. For Medicare, patients can get a new cushion monthly, and we recommend that they do that and keep up on it. As you know, men, especially the stubble from their whiskers, will break down the silicone in the mask and cause it not to seal adequately. The ResMed F20 series seems to be a highly adjustable mask option that seems to fit a lot of faces and especially works with men with beards who need a full face. As you can see here, we have some pictures of what the patients may think they look like with the CPAP mask on. We know that's not accurate. Mask liners are fabric that sits between the mask and the face. It may help resolve leaks. It may increase comfort and redness to the face. They're made to be changed daily. They come in a pack of 30, and they're not recommended to be reused or cleaned. So they're just like a little piece of fabric that looks like a t-shirt material, and it sits between the mask and the face and kind of seals up all those little leaks. A lot of times that little tiny piece of fabric that looks too simple to do anything can make the difference in compliance for the patient because it takes pressure off the bridge of the nose, it seals leaks, makes the mask fit better. So that is something, if you haven't explored mask liners as an option or accessories like those, it's important to be aware of them so we can advise our patients and possibly have them in the sleep lab too to use if you have issues with leaking with our masks during the night. There are gel pads that can be used on the bridge of the nose to help reduce that area that generally gets reddened from the CPAP mask. These also are 30-day use, and they're great for thin-skinned bridges. Be sure to use your fitting guides. If a mask is too high up on the bridge, it will leak, and if it's too low on the bridge of the nose, it'll cause soreness. Mark the straps for your patient at the desired tightness so that they have a reference. You know, mark the straps with a magic marker and okay, this is how tight you should have it when you first put it on. The other thing I find with these machines that patients have at home is unless they have a feature where they can check their mask fit, when they start out at a really low pressure, the patient doesn't need the mask so tight or snug. And then as they fall asleep and the pressure goes up, well, then the mask is leaking. So that's why I like to mark the straps at the desired tightness so the patient can have a reference. Under the nose, mouth, cushion type masks might be useful for patients who like to wear glasses with their CPAP on. Believe it or not, some of our patients like to sleep with the glasses on. It is a good interface for those who like to be able to see over the mask. Sometimes the mask being on the nose kind of obstructs the vision, and some patients don't like that. Many of our masks have some degree of auto-sealing properties. The patient will be turned off to therapy if the mask is too tight. So, and again, if you just pick up the mask and reseat it on your face, it can create a natural seal. Train the patient to adjust the straps themselves, because that is essential as they're moving and repositioning during the night. It's great to have a variety of masks available in sleep labs. I've worked in sleep labs where we had lots of masks, everything under the sun, and then also in sleep labs where it was slim pickings, where you had maybe 1 or 2 varieties of nasal mask and 1 or 2 varieties of full face. Sometimes less complicated, if the less styles of mask, it does complicates things less in the sleep lab. But I like having a variety of masks, having options to change to if what you're using isn't fitting or isn't comfortable for the patient. Even the weird little masks, like, you know, if you've all seen that cloth mask, that's not plastic or silicone, it's like a cloth mask, or, you know, the old one that fit over the whole face, eyes and everything. You know, some of those weird things might be just the thing for the hard to fit patients. Accept samples from the vendors. The vendors are more than willing to give you their product to try out, to, you know, here's a couple of our newest masks. Go ahead and try them and give them a chance too. We all in sleep labs, I think, try to develop our favorite masks, our go-to masks. And it's hard to accept something new sometimes. So you have to try the mask and give it a chance and learn how to use it before we make a decision whether it's a good one or not. Home care companies should use mask replacement programs when needed. A lot of these companies will give you exchange a mask if it's not working out for the patient within the first 30 days, and the DME home care companies should take advantage of those programs. I love this. I come from a wrestling family, and I love this picture because when somebody would have a facial injury or something, they'd come out and wrestle in this mask, and we'd be like, yeah, the full face mask. But that, I think, is maybe what it feels like for our patients. Nasal pillow type applications, everybody wants them. Not a lot of people can use them. I let the patient try it if they want to, but you know, everybody will come in and say, I want those 2 that go up your nose. My neighbor has that. He said he couldn't wear it until he got that. So I think it is, it looks like less, so people are more drawn to less on your face. And if it works for them, that's great. Like I said, if it works for them, let them have it. Nasal pillow type applications are easier to fit than ever before. They come in multi-size cushions. They're easier to get on and off. Glasses can be worn with them. Only drawback to them is they have to be able to breathe through their nose well and keep their mouth closed for them to work. Sometimes patients, I think, too, don't like the sensation of it blowing right straight up their nose. So now we have those nasal pillow type interfaces that are just like a cushion that sits up against the nostrils, and that can be something that's more comfortable for our patients. Face redness, if the patients are complaining that redness from the mask, check the mask fit. They may want to have 2 different masks to alternate between, to change the pressure points. A Band-Aid over the red area or a moleskin to act as a barrier can help. Hydrocortisone cream during the day. And a lot of women, as you know, don't like strap marks. You know, when you can see the marks that are made from the CPAP straps. Putting piece of fleece in between the headgear and the face can help eliminate those strap marks. Changing out masks, like I said, if you can get a new cushion every month, get a new cushion every month. If your insurance says you can get a new cushion 3 times a month, or I'm sorry, every 3 months, get one every 3 months. So as often as you are able to change out the mask, cushion, and headgear and everything else that so you have good working parts to your mask. Basset trace and ointment in the excoriated area sometimes can help. Using ivory soap or a very mild dish soap to clean the mask, and making sure the mask is rinsed off and no soapy residue is present can also help with face redness. Some patients just need a little more TLC. You have to go slowly with them. You have to explain the process. You have to let them try things, let them feel it, experience things. You just gotta sometimes use baby steps to get the patient to wear the device, because first time they put it on, it can be scary for them. So keep that in mind. Try different interfaces. Try auto CPAP, increased humidity, heated hose with CPAP. Use the downloads and follow up with your patients carefully. The PAP nap is a tool developed by Dr. Barry Craco. He developed this for patients who are struggling with therapy and have exhausted all their resources with the home care company. They need fine-tuning with the settings. It's a daytime nap with a few electrodes on, preceded by relaxation training and mask fitting. Can be helpful for people who are struggling to become compliant with the CPAP therapy. And there is a code we can use for the PAP nap. It is a billable procedure. Graded CPAP exposure therapy can also be useful. Having the patient just hold the mask to their face, then finding if they get comfortable enough that they can actually put the mask on, but with no pressure to it. Then they wear it while they're awake at a low pressure, not even trying to sleep with it, sitting up, watching TV, listening to music, and so on. Then maybe they'll lay down and wear it for a nap period. And the goal is to work themselves up to wearing it 1 hour at a pressure of 10 centimeters. So for patients who are failed split night, you tried a split night or you tried a CPAP titration, they just couldn't do it. Sometimes this method of graded CPAP exposure therapy can be useful. And a lot of support by the tech to get the patient through this process. With the certified sleep health educator role coming on the scene, it's filled the gap between the sleep center and the DME. Appointments can be made for the patient to come in and work with a sleep technologist to resolve any compliance issues. It is billable with the code 94660, and can be useful just letting the patient try different interfaces, showing them, like I said, a lot of times the biggest issue that I find is the patient is not putting the mask on tight enough or not adjusting it when it loosens up because they reposition during the night. Keep the lines of communication open between your home care company, the manufacturers, the vendors, the sleep lab, the doctor's office. Have good relationships with your regional and local reps. Bring all the parties together, and close follow-up is a key to good compliance. A 1 to 2 month home care company face-to-face follow-up is recommended to discuss the therapy results, how things are progressing. These are the Medicare requirements for standard compliance. 30 to 90 days, they must prove compliance, so it's a rolling. In a 90-day period, 30 consecutive days, they have to be compliant 70% of the time. So they have to be wearing the therapy greater than 4 hours a day, 21 out of the 30 days. Patients must also have a follow-up with their sleep provider to discuss the therapy 31 to 90 days after starting therapy. And as I said earlier, BiPAP may be a good option if you're nearing that 30-day mark and the patient is still not compliant. We're winding down. We're getting there, guys. CPAP takes some getting used to. Don't give patients the option of using it when they feel like it. Say you have sleep apnea, this is the treatment. It's important that you use this therapy, and we're going to help you get through this. Explain the first 1 to 2 months there may be an adjustment period, and give a lot of support to get through those bumps and bruises along the way. Encourage the patient, like I said, I always say don't give up on it and don't put up with it. You know, sometimes patients feel so good, but they got a big red sore on their nose and they'll say, well, I got this, but I feel so good, I don't want to stop using it. No, we'll find you a mask that doesn't give you a sore on your nose, or, you know, and encourage them not to give up on it. Every issue they have, hopefully we can find a solution for. And it's the trial and error method, you know, if something doesn't work, try something else. But successful use of CPAP can greatly improve the quality of life. And like I said earlier, I always tell patients, and I almost get emotional when I tell them sometimes, you know, you got everything to gain and nothing to lose by trying this. You can always go back to the way you were before, but what you might find is you sleep more soundly, you feel better during the day, relationships improve, etc., etc., etc. And I explain to them it's kind of like putting your glasses on. You can't see, you put your glasses on, you can see. You have sleep apnea, you put the CPAP on, you don't have sleep apnea anymore. It'll work the very first night you wear it. It will continue to work, but the key to it is you have to successfully wear it. And that's where we as sleep techs, DMEs, providers come in. Use all the resources we have available, and hopefully we can improve the success of long-term compliance for all of our patients. So thank you very much for your attention.
Okay, we are back and stopped it a couple seconds early so we can keep moving right along. I've been asked to make a couple of announcements. In room 1, our next talk is going to be Dr. Sri Naik talking about non-invasive ventilation. So if you're interested in that, you can stay here in room 1. Otherwise, over in room 2, Dr. Dan Taché is talking about oral appliance adjustment. So if you want to jump out and go over to room 2, you're welcome to do that at this time. Also, because the presentations in room 2 ran over a little bit, we were not able to hear Dr. Alex Villarreal at 10 with bruxism and other sleep-related movement disorders. We are going to be holding that talk in room 1 during the lunch period for those of you who want to hear about bruxism and other movement disorders. We did update the link, and you can just jump into room 1 at 12:15 and hear Dr. Villarreal. So without any further ado, I'm going to go ahead and share Dr. Sri Naik's presentation on non-invasive ventilation.